Welcome, Dr. Moore.
Well, thank you very much for letting me be a part of this, and a special thank you to Dr. Cherokee and for her enthusiasm in all of this and helping pave the way, and it is a privilege to be a part of this. It's very humbling to be here in front of you all, and thank you. Thank you very much. And hopefully we can make a difference in the future. You know, as we look at these different things, lots of times it seems like it's science fiction. It seems like some of these things will never come to pass. But I'll tell you, the road has already been paved, and folk have gone down this pathway in other diseases. And what I'd like to do is give you a little bit of background behind transplant, and how it's been used for diseases, and why this will become a reality. So let me move on here. So I have the privilege of being able to work with kids, which is my greatest joy. And I do bone marrow transplants for kids, and we do it for a variety of different diseases. Everybody's aware of patients who have cancer that have bone marrow transplants. But people are a little bit less aware that for many years now, in fact, the very first transplants were done for children who didn't have normal immune systems. They were missing a protein, missing an enzyme. And that goes all the way back to 1968, if you can imagine, and successfully done. So we now have over 40 years experience in doing bone marrow transplant for children who are born with inherited disorders. And as already been mentioned, there's different types of cells we can use. Bone marrow everybody knows about. Cord blood cells were brought up and discussed. And peripheral blood stem cells, where we can actually harvest stem cells from the blood. For patients who have metabolic storage diseases, which is a great picture for us to use and look forward, over 500 patients have been transplanted for those over the last 30 years, many of them successfully. For some diseases, however, it's successful, and others it isn't. I have listed here different diseases for which it's been successfully done, and others for which it's been tried that weren't successful. So for everything, we need to move forward realizing that things may work or they may not work. We just had a little girl just a few months ago with the Metachromatic Leukodystrophy have a bone marrow transplant. I saw her in clinic yesterday. She's doing great. She's gaining new milestones developmentally. But unfortunately, her brother was in clinic also who never had an opportunity to have a bone marrow transplant and was neurologically deteriorating and doing poorly. We have folk who have been transplanted from some of the diseases below, some of which had a little bit of benefit and some none at all. So why does it work? Why do stem cells from the bone marrow get into places, and why does it work? It turns out that stem cells from the bone marrow take up shop in multiple different organs in the body. You can see that cells get into the brain, cells get into the lungs, into the liver, into all different kinds of tissues. And there, they can share either a missing enzyme or a missing protein with other cells. So success depends somewhat on, number one, Dr. Cherokee was talking about this, how much of the cell and how much of the protein and enzyme is actually being shared. So is it getting into the right place? And then even if it's getting in the right place, is it making enough? From the mouse model that's been shared, we see that it does, but we don't know yet for humans. So I want to walk you through, some of you are aware of this, but walk you through the bone marrow transplant process and what's involved. So first of all, bone marrow has to be harvested, and although we can get it from cord blood, that quantity is insufficient, and you would have had it already saved away, insufficient in volume for a larger adult, and you would already have to have it saved away in order to be able to use it in this process. Bone marrow has the longest record. It engrafts more quickly than cord blood and less chance of not engrafting. So how much bone marrow does it take? It takes about 1 teaspoon of bone marrow for every pound of weight, a person's weight, to get enough cells to engraft. And that's been shown over a long period of time to be successful for patients. But that's a lot of bone marrow. So how is that collected? Well, it's collected in the operating room, and the donor goes under anesthesia. It takes about 30 minutes to an hour to collect, and where it's collected is actually from the posterior part of the hip. So if you feel bones back in here, one little hole in the skin on each side, but multiple holes in the bone itself. So when someone comes through that, they're pretty sore. It's like they're out playing football and got hit in the back there several times and real bruised, but they recover. Well, now how much bone marrow does a person have? And are you taking away so much that it would hurt the person? Or would they have trouble in the future? Well, what we take, even though that volume is large, is just a fraction of the capacity of how much bone marrow you can make. You can easily make bone marrow for, it's estimated, at least 10,000 years of life, because it replicates and some of the cells stay in a quiet state and only are called up when they're needed. So what we take doesn't impact that and doesn't impact the stability of the pelvis as well. So after that's taken, then it is processed. And that may be very minimal processing, or it may include taking out some of the red blood cells. It all depends if people are different blood types. So you can be a perfect match the way the immune system looks at each other, and yet have different blood types as well, and it still works. Also, again, it was mentioned, we look at bone marrow transplant as a transition step. It's a proof of principle. If you can do a bone marrow transplant and get sufficient cells into sufficient places and halt progression of disease, then that would be the gold standard. And if you can do that, then gene therapy would be the next step, which would be safer. Gene therapy tends, in current technology, tends not to deliver quite as many cells as you would with a bone marrow transplant from using cells from other folk. And so you really want to establish this first. Let's move back here. There we go. All right, so how do you get the cells in? You do a surgery to harvest them. To get them in, you just infuse them like a blood transfusion. However, before that step comes a very aggressive step. And for 1 week prior to infusing the stem cells, a patient, and we'll go into more detail about that, has to have something to make space. Two types of space you have to have. One is physical space within the bone marrow, and the second is immunological space. We all have immune systems, and immune systems work very efficiently at getting rid of things that are foreign. So if we were just to infuse the stem cells and not do anything to prepare ahead of time, it would be rejected by the body, by most folk. So in order to do that, we do a couple of things. One is we give chemotherapy, and in the case of inherited diseases, we don't need to use radiation typically, with rare exceptions. We use chemotherapy, a week's worth of very aggressive therapy. It's very strong, and it's aimed to wiping out the bone marrow so that the space is empty. It's also geared at wiping out certain cells of the immune system that could potentially reject it. In addition to that, we add in an antibody that also takes out those cells that can reject it as well. So following that week of the therapy, you have the infusion of the cells, and then typically you have to wait at least 2 weeks for the cells to begin to grow and to engraft. So if you're in the bone marrow here, the cells are there, they're reproducing, and they start to form all of the different mature type of cells, which can then, as per the previous slide, migrate to different tissues. During that time, there are a number of risks, and we'll get into those in a moment, but a person is kept in what we call protective isolation. Many years ago, that used to be a room with a bubble and gowns and gloves and all those kind of things, and we have learned over time what's most important and what isn't quite so important. The most important thing is a good air filtration system in the room, keeping sick people away, and washing your hands. And all the fancy things that people have looked at doing many years in the past have not made really that much difference. Those three simple things are what you need to keep a person safe. We'll talk more in a moment. So, we talked about other diseases for which it's been successful, but to my knowledge, it has not yet been done for this disease. So this would be the first. Again, this would be a bridge to ultimately would be replacing the defective gene for folk and just putting the new gene in and giving a person one's own bone marrow back. So as we know from Dr. Cherokee extensive research that laid the foundation for all of this, that in mice, this can make a difference. So this is the work of a lot of folk, and attacking it from a lot of different ways. There's been a lot of input put into this, a lot of support, and more than 2 years of work. And you always hear of these timelines in 3 years or 6 years, something will be available. Into the institutional review board's review alone took more than 6 months, and multiple back and forth discussions to be sure that they were satisfied with the safety of the process and the wording of consents and those kind of issues. So this will be done at UCLA Medical Center, and we're really trying to find out 2 main things. One, obviously, does it work? And secondly, how safe is it? When I say safe, we know a little bit about the safety of transplant from 40+ years of experience, but transplant with kidneys that may not work so well, or the other problems with the body that may not work so well, we need to know how safe this whole process is. So we're going to look at those 2 things. That's the main point of that. Does it work, and how safe is it? So this is just a pilot study. As Dr. Shirky said, we're only going to take a look at 6 patients. With 6 patients, we should be able to receive all the information we need. We're going to follow folk lifelong afterwards, okay, for purposes of the study for at least the first 2 years. But all patients who have bone marrow transplants are followed lifelong. Accrual period we've allowed for this is 3 years. As Dr. Sharkey said, if things go well and patients are doing well, then we can obviously look at moving forward and at least preparing things for gene therapy sooner. And if not, then we also know that we need to stop early and not pursue this. So I've listed a conditioning regimen, and it uses different drugs. And this is what we call a reduced intensity regimen, and what that means is the therapy that we use is less than what you might use if you're going to treat somebody with a cancer. There's no need to give the degree of therapy to wipe out some malignancy. We don't have to use radiation. We don't have to use the ultra strong drugs. But that being said, these are still very, very strong. So fludarabine is given. It's a drug that's given IV for 5 days. There's a drug called busulfan that's given for 2 days. And those are the chemotherapy drugs. And those are, again, geared to wipe out the bone marrow, make space, both physically and also immunologically. And this is anti-thymocyte globulin. It's actually made not in rats, but bunnies. And so it basically takes your T lymphocytes, which could help reject the graft you're putting in, and basically takes them out of action. Now, one of the side effects of transplant, you're all familiar to a certain extent with organ transplantation and the risk of rejecting the organ. If an organ comes from someone else and it goes into your body, your immune system is competent, will go and say, it's foreign, I need to attack it, I need to get rid of it. With time, you start developing something called tolerance. With bone marrow transplant, however, the issue is much more profound, because as you're doing a bone marrow transplant, you're actually transplanting in a new immune system. So that new immune system, when it goes into the body, the whole body is fair game for it to attack, because all of the body looks foreign. So because of that, the immunosuppressive medicine to suppress the immune system up front is very, very strong. But the beauty of it is a large proportion of people actually develop what we call tolerance. And the new immune system gets re-educated so as to not attack a person's own cells. This being said, the majority of patients actually for the transplant have the potential of getting off all of their immune suppression because that tolerance develops and it accepts the body over time. So the bad part is it can attack everything, and will try to attack everything unless you have medicine to suppress it. The good part is it has the potential to develop tolerance. These are the medicines, excuse me. These are the 2 medicines that will be used for that. So, eligibility. So we want to do the safest type of transplant we know how. Allogeneic means from another, and so although it comes from another, we want the very closest to same as possible. And so we want someone who is perfectly histocompatibility matched, but also not with the disease. And so that's the trick. We want to find somebody who has a separate match. And so what's our experience with other diseases? Well, actually, it's not unusual to find a sibling who neither has a disease, but is also perfectly matched. This is the safest kind. Why? Because when we match, and we match on a DNA level, when people have that much in common, the new immune system sees proteins on the cells that people have and say, hey, you look just like me, you're okay. Now, there are very small differences that each of us have. You could have two brothers with the exact same immune system, but if one has a disease and one doesn't have the disease, there's got to be something different, right? And so even the immune system may have minor variations. And so even when you have a perfectly matched brother or sister, you can still have the immune system attack us. This is what we call graft versus the host disease, or GVHD, when the immune system attacks. But we're going to take perfectly matched on DNA level only siblings. Also, we have to make sure people are very healthy. So there are a number of tests that will be done and performed to make sure that going into this, a person is healthy enough for the process. These are criteria that we know over the years for patients that if we meet those, they have the best opportunity to get through safely. That being said, because this has not been done in this disease before, we want to be very conservative. And as we look at function, we're going to make sure that kidney function is stable prior to going into this. So there are two main groups that we're going to take a look at, one with adults and one with young adults. And the adults, we're looking at people 18 years and older, and we're looking with stable kidney function. We want to make sure that over a period of time, for at least 12 weeks prior, that there hasn't been any significant change in that. They also have to show evidence of the disease progressing. And so those I've listed there. The second category are young adults. There is some debate on going at a younger age. With a lot of thought, we felt, even though, interesting enough in transplant, the most successful ones are in the youngest, such as babies. We felt that you really needed to have come to a place where there was a fair amount of problem in taking the medication. It wasn't just maybe a younger child who didn't want to take it, but actually not tolerating it. And we felt that to do that, it was safest to go with the adolescents first. And so there was a lot of debate, especially with the regulatory folk, because they actually said, why are you not doing babies and smaller children where this might have the most benefit? And we said, well, you know, those children may also still benefit from enzyme replacement, or with replacement therapy. So this is where we're at on this, and it's basically a teenager who doesn't tolerate taking the medicine. And as you see, it's not just, I didn't want to take it today, but it's really some definitive measurements to show that things are building up. And then also, over time, that's the case. And then worsening clinical manifestations as well. Now, why are we being so strict on this? Well, a little bit will be explained by the endpoints we're looking at. What we want to see is event-free survival through this process. And when you're talking about survival, that brings up bad things that can happen. And bad things can happen during transplant. We'll talk about those in a moment. But we want to make sure, first of all, that there's survival without any disease. If we're going to look if 4 out of the 6 patients aren't making it, the whole thing gets shut down. Also, if we see disease progressing despite the transplant and it getting worse, that also is a reason that would stop the study. So secondary endpoints we're looking at different laboratory manifestations, the biopsies that were mentioned, and then a number of other things. So we're going to follow these secondary endpoints. We're going to look for progression of disease. We're going to look for overall survival. We're going to look at the central nervous system complications and cognitive problems. And then again, cysteine accumulation. Is it working? Is it effective? And it may be, as we've heard already, that some areas of the body may be able to dispose of this just fine, and others may have actually no ability because they may not get there, or they may not be able to share enough protein to make a difference. So risks of transplant are significant. We're just, again, want to make sure that people get through this process and can get through it alive. And so what are the dangers of this? Well, first of all, that the marrow doesn't engraft. So we could put the new bone marrow in, and it may not engraft, it may not grow. And although it's a low probability with what medicines we're using for it not to come back, that is a possibility. So one could then have to be rescued with more bone marrow. But that's one of the reasons we're using a sibling, because even if it doesn't grow back, we can go back to the sibling, get some of those cells from the blood instead of the bone marrow, and rescue a person with that. So we're going to look at that. We're also going to look at how much of those cells engrafted. What if only 10% were from the donor and 90% turned out to be the only person's cells coming back? Is that enough to change the disease if it's a mix? Or do you need to get all of the donor cells in? That's our goal, to get all of the donor cells in, but we may end up with a mix, and we need to look at that, and also need to look at outcome with it. We have to look at some typical things for transplant and compare them to how we know people generally recover a transplant. How fast do different parts of the blood come back? Do they come back in a timely manner like other types of transplants, or is there some kind of delay? We have to know how much of the graft versus host disease, which is where that new immune system is rejecting the body, both acutely, so in the first few months, but does it hang on long term and a person not develop that tolerance? We need to know that. There are a lot of transplanted related complications that we deal with. Routinely in transplant, is that going to be worse in folk that already have disease on board that may predispose them? And we don't know this. Again, why we're being very careful. And then infection. There's no immune system at all for a period of at least 2 weeks. None. And so a person remains in isolation. Following that, as the immune system comes back, it comes back almost like that of a newborn baby. And you know, with a newborn baby, you have to be very careful who they're exposed to, because they can catch things and it can be life-threatening. So it is after bone marrow transplant. From a sibling, it takes at least 3 to 6 months for enough cells to come back so that you can be walking around in public. And we test for those things, and we know the standards that we'll be looking at. You have to be re-immunized all over again, just like a newborn baby. Cells that fight off viruses tend to come back much later than cells that fight off your normal type of germs. So that too has to be followed and looked at. How fast does the immune system reconstitute? So you see, there's a lot of questions that we don't have answers for. However, as we said at the very beginning, there are many diseases that the road has been paved for. The most common, or rather the very first disease that transplant was for, as we mentioned, was a child with an inherited immune deficiency, bubble baby, as commonly known, who was treated successfully. And although this sounds a lot like science fiction, we have in our hospital children who have similar type diseases who are, as we speak, being treated with gene therapy. So it's there, they're being treated. As we test their immune systems afterwards, gene therapy is successful. So even though this bridge that we hope will lead to something even better and safer in the future seems like a huge path, that path has been paved before. It is a reality in other diseases, and there's no reason why it can't be a reality for us as well. After work of everybody together, we are so thankful that on Thursday we got approval. So we will still put in some amendments and do some changes. As we move forward, we will be in contact with Nancy and the CRF, and inquiries about moving forward will go through the CRF first. There'll be a screening process. And again, as you see, this is a high-risk procedure. Or a person's life is at stake when they walk into it. It's not a simple thing by any means. We want to be very selective. We want people healthy enough, but also whose disease is out of control, who we think we can make a difference in. Thank you very much.
Thank you, Dr. Moore. Questions?
Hi, I have a question about creating immunological space in the patient. What risk does that pose to the transplanted kidney?
Okay, that's a great question. That's actually a very, very good question. So one drug in particular in there, especially the busulfan, can cause significant problems, as can the fludarabine. And that's one of the reasons why we're using the reduced intensity conditioning. There is a conditioning regimen that contains some of those same drugs that's much more aggressive and much more harmful to the kidney. So we'll be monitoring, but that's why we're using a reduced intensity conditioning regimen, and that's also why we're following kidney function so closely through the process. The speaker who follows me will, after the break, will probably be able to address that even in more detail.
The guy with the nice shirt back here has a question.
So is there a time frame on the 6 patients? I mean, when you get approval like we did on the 19th, is there a time frame of which the 6 patients need to come forward, or is that just kind of in perpetuity?
So as folk come forward, they'll be screened initially. So we want to, first of all, we want to accomplish all of that within a 3-year period. As we see success with initial patients, I think in parallel with that, not after that, efforts as far as gene therapy, working on the gene therapy protocol will run parallel with that as if we see some success with it. But for folk that are going to actually be part of this screen, first of all, we'll go through the CRF. We're actually putting in an amendment already on the approved protocol that will put exactly how that process will take place, how each step of the screen will take place. We've had a lot of discussion back and forth on trying to be sure that, again, it's the right candidate, someone who's not really, really healthy and doing really, really well on replacement therapy, but somebody who actually is having difficulties and some problems, and yet at the same time healthy enough to make it through a transplant. So as one patient is entered on it, we'll see how they're doing, see if they make it through transplant well. If they're doing well, then we'll consider the next one, and that's why it's a 3-year period, because we want to space it out enough so we get some experience.
So you don't have to have all 6 lined up. You just find the first one and go. Is that correct?
Absolutely.
So is it as soon as we find that first one you go, or is it?
As soon as we find that first one, then there'll be a series of eligibility criteria to make sure that we have the right person, and if we do, then it can go forward.
Great.
You showed a slide that outlined the diseases that have been cured and you've had success with at UCLA, and then some where it didn't work. Have all of the, is there always a mouse model?
That is a great question, and the answer is no. For many of them, most of them, the mouse model does support what you see in transplant, but there are occasionally surprises. And that really is not so much, there are differences obviously between mice and men, significant differences, but also the mouse model, although it may be very similar to the disease, may not be the exact genetic problem of the disease. It may just be similar. And it's in those situations, which is unlike what Dr. Cherokee done, which is a very nice and I think an almost perfect model for this. It's in those other diseases that you most likely see there are going to be differences. Again, and the process, I'll just say that, is that once you, and I didn't say this and I meant to, is after a transplant, our experience from other diseases, it usually takes 3 to 6 months for those cells from the bone marrow to populate areas throughout the body sufficiently enough that you see halting of the disease progression. 3 to 6 months.
Do you use the fluorescent just like in mice?
No, not in the folk. So we'll be looking at surrogates for that, like the GI biopsies and some other things.
Let's say it doesn't work, unfortunately, and you have to go back to a kidney transplantation. Isn't there a risk of faster rejection or troubles for the new kidney you implant?
That's a great question. At UCLA, there are so many transplants for so many different organs that we have multiple folk where we actually have the experience of them having bone marrow transplants in people who have had organ transplants and vice versa, and sometimes a in one case, a liver transplant followed by just 4 weeks later a bone marrow transplant. Surprisingly, the immune suppression for the bone marrow transplant usually far outweighs that for the organ transplant up front. But the potential, you would then have to, if you're doing a subsequent renal transplant, have to match for the new bone marrow. And if it's a mix of the old and new bone marrow, then I would let somebody more expert in renal transplant answer that question. But it can become tricky if you have a mixed system. But usually in that case, you have the tolerance present. And if you have tolerance present, you'll usually accept the organ with immune suppression.
While they're recovering in the process, do they live in a room that's isolated for them where they have their own kitchen, or do they actually stay in the hospital for how long?
So stay in the hospital, and it really depends somewhat on how a person's doing with other problems other than their immune system. Generally, within 2 to 4 weeks, a person's immune system is beginning to recover to the place that we can start considering whether they can go home and whether other things are going on. For example, if somebody has a serious infection, that will prolong their stay. If the new immune system is not accepting their body with the medicines we have on, and we have to add other ones, then they may not be able to go home. If a person isn't eating very well and able to sustain their nutrition, that's another reason people stay on. But anytime after, we're a lot different now than when they were 40 years ago. And so we know that the hospital, although we can do a lot of things for a person there, we also don't want them to stay in there very long, because the longer you stay, the more your body can get colonized with germs in the hospital. That being said, patients get routine baths to get rid of those germs and all those other things, but we do look at when a person, the fastest a person can go home safely, we get them home.
Thank you, Dr. Moore.